Welcome to this new video lecture of Digital Rehabilitation channel. We will see together in this video lecture a post-extractive management of the mandible case in a male patient. This is the X-ray, and we see now the three-dimensional reconstruction, the implant software planning. This is novel clinician planning or software planning. We will check the anatomy of this patient, checking the undercuts of the mandible. Always we check the undercuts of the mandible. We see the remaining opalescent tooth. We can sign the nerve as usual, and we'll see the matching of the STL file of the model. And we are checking now the perfect fitting of the STL file of the model on the tooth of the DICOM file of the CT scan, and we see in white the wax-up of the profile, prosthetic profile of the provisional restoration. Now we can go in planning for implants for this patient. To anterior, we had a big amount of bone here. Checking now the perfect positioning of the implant respecting to the width of the crest and the distance between the implants and the tooth, leaving the space for the metallic cylinder. We have enough space here. We need no interferences between the roots and the implant planning, and two posterior implant in the first premolar area. We have a good anatomy on the right side with big amount of bone here. We can remove the cast, and now we can go planning the anchor pin, 3 buccal anchor pin and 1 lingual. And this is the virtual designing of the surgical guide. We are checking now all the situation. Maybe we can show also these 4 parallel implants, because parallelism is a prerequisite for applying the pre-made prosthesis. And we see also the panorex X-ray checking all the situation. This is the prosthetic phase when the guide arrives from the company. We use the guides for fabricating the prosthesis. So we take the guide and we secure the analog of the implant to the surgical guide, and we create some holes, as you see on the right in the cast. We can put at this moment the guide onto the cast, placing, as you see in this situation now. You see in the middle the attitude of the analog secured onto the surgical guide. We create some hole in the cast, as you see on the left, and we can replace creating some holes corresponding to the place that of the implants that have to be placed, and we secure the surgical guide onto the cast. So we can create the model cast, and you see also the articulator with the resin relining of this pre-made prosthesis. So we can go, let's go to the surgery. Okay, let's start with the surgery. This is the intraoral situation of the patient. You see the remaining tooth. We are checking now the amount of the keratinized tissue in the place where we are to place the implant. This is the only thing that we are not visible on the CT scan. And this is the guide. This is Smart Fusion guide from Nobel Biocare. We bought that guide, born from the master cast. So it's very, very fitting and precise. We choose the narrow sleeve for this implant thanks to the use of Nobel parallel implant, that is the implant of 3.75 of diameter, but is able to enter into the narrow sleeve, and we have the occasion also to check if we have some problem to enter with the sleeve and solve some conflict between the two, between the older
of the reductor and checking which is the best way to enter into the mouth of the patient with this tool. Now, after the checking of some conflicts to how to better handling the surgery, we can enter into the mouth of the patient with the guide. Checking the fitting of the guide is very, very stable. And now is the moment where we are fixing the guide. We don't need, you see, applying the force with the finger in the back of the mouth of the patient. We can try to stabilize the guide during the stabilization phase. This is the 1.5 millimeter drill for the anchor pin. We start usually from the middle. We start usually from the middle here. Very, very gentle movement to perforate the bone. We have the cortical of the bone to break with the tip of the tip. We place the first long anchor pin in the middle. Then we start with the left anterior pin. The assistant had to retract, correct the lip to leave the surgeon at the free way to enter with the drill, like this. Fai vedere che la pulisci, fai vedere, fai vedere. And very important things to do, that the assistant every time have to clean this drill from the bony debris to recover the cutting performance of this drill anytime. So you drill, place the anchor pin and remove the bony debris from the drill to recover the cutting performance. So we have a very stable situation because this guide is still supported and fixed by 3 buckle pin, and as usual, you know our philosophy to stabilize the guide with a lingual pin, and see this use of this retractor to the floor of the mouth of the patient to prevent that some soft tissue entering beneath the guide, and we risk to perforate the floor of the mouth with the drill of the anchor pin. And this is the choice of the shorter lingual pin, that we are better handling the surgery for the tool because it doesn't interfere with the reductor of the drill. So we start with the surgical step, and the first step is using the tissue punch, the circular mucotomy. We use usually this instrument here to control the vibration, because this drill causes a lot of vibration. We may displace the guide a little bit during the handling. Little pressure. You have to be sure to cut it. You have to be apply a little pressure to be sure to be cutted all the soft tissue all the way around the circular incision. When we had a big amount of keratinized tissue, there is an indication to use the mucotomy. This is the countable drill that I showed you before in the surgical handling. And this drill is able to remove very easy the soft tissue the previous cutted soft tissue that you can see that is easily jump outside. We have to open at the maximum. We use this countable drill now in the frontal area, and you see very easy to remove the soft tissue that easy jump through the metallic sleeve. And also we are creating, thanks to the particular shape of this drill, the first access to the coronal part of the bone, breaking some knife edge or some cortical bone. Questo, aspetta, sì. Questo è parallelo. Sì. This is the countable drill for parallel drill. So we have countable drill for MK3, MK4, and this countable drill that you see now is strictly dedicated to novel parallel implant. Now we have created the access to the bone, and we start to drive the drill. According to our protocol, you see, we have, anytime we have to indicate the reduction of the drill is very easy to read, the diameter and of the sleeve, narrow platform, 2 millimeter drill, and the drill itself is 2 millimeter. We enter to the mouth with both holding the reduction of the drill and the drill itself, and we starting to cut. Apri Marco, grande, grande. Look at the movement, we have to break the cortical now. We touch the bone a little bit and go back. And this movement allows us to let the irrigation enter into the osteotomy, allowing us to prevent overheating of the bone. And also these flashing movements are able to... Applicando.
No, tiro giù.
Paziente?
No, fermo. Si tira una mano su, vedi che lui viene indietro, si ribalta indietro, io non riesco a muovermi.
Così.
Però...
Vai. Fermo così Marco, apri grande grande. Ok, we are setting the... We have to be sure that we are entering in the correct position with the slave. Now we are in the right position. The first mark is 7, the second mark is 10, and the third mark is 13. And as you see, we are creating a over preparation in length. As usual, we prefer to overextend the preparation in length, flashing movement to prevent overheating of the bone, and also this movement, this flashing movement, helps the surgeon to recover every time the right positioning, avoiding dangerous deviation while they are driving the drill. Now we are checking the right positioning of the reductor, because there is some difficulty, but thanks to the holder of the reductor we can enter lingually. It's a novel biocare. The possibility to make an angulation of the reductor is very smart philosophy to enter into the mouth of the patient when we have some conflict between the two. And now we are perforating all the site with the 2 millimeter drill. 2 millimeter drills is important because it gives to you the sensation of the local bone density. And now Giampiero has recovered give the information about the bone density. Okay. When you are in position, you have to wait and control that you are in the right position. Okay.
Apri.
Okay. Apri grande.
Apri.
Apri grande. Parlo io, devo rifare. Lo so. Ok. 2.8. 7 millimeter now.
No.
It's not so easy to handle post-extractive management of this patient because you have a big conflict between you have the tooth, and the opening of the mouth of the patient is so critical. But anyway, start to drill only if you realize that you are in the perfect position with respect to the patient and into the mouth of the patient with drills and everything. We have all the way free to drive the drill like this. As you see, very slight, gentle movement to prepare the bone very, very gently without driving the drill in one shot in the right depth, because if you go in one shot down with the drill, you are sure you can enter in the vision, and so you can impair and jeopardize the result. Look at this movement now, flashing movement, very, very gentle. Okay. Apri Marco, grande.
Apri Marco.
Now we are in position and we can start to drill. Fleshy movement here. Some very dense bone in this side, maybe. Oh. Remember the protocol? 2 millimeter here, 2 millimeter here, 2 millimeter here, and 2 millimeter here. 2.8 in all the sides. Now we are approaching to place the first implant, and we start with from the back, and we choose the 3.2 because we have in the mandible. We are every time undersized with respect to the final diameter of the implant.
Apri grande Marco.
Grande Marco. Apri grande, vai. Okay, we come down with the 3.2. Remember this side, we need 10 millimeter implant. It's shorter than the other because we have the lingual undercut. Okay. We have a good quality of bone. We realize we are in the mandible, in the symphysial area, so we have to manage the protocol for the dense bone. We use the conical drill for dense bone dedicated to the conical replace implant. This drill, we use this drill for such kind of rectification of the sites when we have a very dense bone in the coronal part, because the apical part doesn't interfere with the previous made osteotomy and break only the coronal part. We have some stop. We have the stop, so we can go very, very safe, touching the metallic sleeve. And then, according to our protocol, approaching to placing the first implant, we take the screw tab. This is the screw tab for parallel implant. And this is movement that we use in reverse section to enter through the guide at the very first moment when we are not guided. Apri grande Marco. Bravo. Reverse section now. Engage the metallic sleeve. We engage the bone. Now we are guided. And I ask the cameraman to enlarge a little bit the to leave the pressure or control the movement only without applying any force into the motor device. We are jumping to screw up at 40 Newton. We can use 40 Newton on the screw tab, not with the implant, please, but the aim is to create the right shape to let the implant enter very easily. Sorry. Now I'm washing inside to the osteotomy to remove the bony debris inside of the osteotomy, because also the bony debris may interfere with the sitting of the implant. This is the 10 millimeter parallel implant, reverse section. Grande Marco, che puoi. At the beginning we are not guided. We insert the implant in the reverse section. We engage the bone. We feel a little jump when we engage the screw tab shape. And then we are guided. We insert the implant. We set the motor device in this moment at 30 Newton. And checking the situation about this implant. We unscrew the implant. Lo levi perché?
Una volta solamente ho fatto. Ok, dammi presa. Un po' sovrappreparo.
We realize that we have a coronal impairment to the tip of the implant. You know, you remember the CT scan, we have the lingual undercut, so we realize that the tip is very near to the cortical, and if we force, we can go in spinning. So we remove completely the implant. We are setting now, it's very important, we have in the mandible, we have in the nerve, so we have to set a stop managing a little bit overextension in length with the preparation, but not so much because we have not to avoid to perforate the cortical. So we need a stop. There is a very smart stop kit from the Nobel biker. And now we show the stop set here at 11 millimeter, 1 millimeter more. To try to have more space in the apical part. Apri grande. We are setting the stop on the 2.8 drill. In the maxilla we never use the stop, but we are in the mandible, so we have to respect the nerve and the undercut, so it's better when you have to force a little bit down. It's more safe to use the stop. Tanto lo cambia. Non è. Okay. Now we are managing the perforation of the osteotomy at 11 with both 2 mm and 2.8, and then we try again to insert the implant. Now we start at 30 Newton, and every time in reverse section we are clean the implant from the bony debris to recover the self-cutter properties of the implant. Reverse section we're setting to 20 Newton to learn something about this implant. Non si vede.
Adesso no, lo tendenzialmente più basso.
Si vede. Non si vede, c'è il dente davanti, quindi
C'è un dente enorme davanti.
meglio. Ok, and it's not easy. Lo posso spostare? And as you see, scusa Marco, gira un po' di qua, li faccio vedere, non vedo niente. It's not so easy because we have the tooth here. We leave the implant a little bit unscrewed. We have not to touch the guide. We have some space here between the implant stop and the guide. We not reach the right depth because we don't want to displace the guide. So the protocol is to drive. We choose. Ecco qua, quella è la bocca. We choose the 3.2 millimeter drill, and we are approaching to prepare the adhesion site. Not jump in this site or this site, but you choose the very closer adhesion site. 3.2, gentle movement, just to perforate very gentle the bone, avoid overeating of the bone and recover the memory, avoiding the pains. And we will teach you how to understand if you enter in deviation by feeling the vibration of the tools. Reverse section for the screw top. Engage the bone, the osteotomy. We are guided now. We use irrigation to remove some friction between the implant mount and the metallic sleeve. Da lavare? I'm removing now the bony debris inside the osteotomy. Okay. And now we are approaching to place the second implants, 11.5, 3.75 diameter, Nobel parallel implant. Remember that this very smart implant in guided surgery, because you have the diameter of the standard old Branimar 3.75 implant, but we have conical connection from the prosthetic point of view and a narrow platform. It's very smart for guided surgery. That's why how we hold the driver onto the implant, taking the implant itself and setting the motor in reverse section. Reverse section, we are free now. We engage the bone. We feel a little jump. That means that we engage the pre-made screw tapping shape to the bone. We have 30 Newton of insertion torque now, and as you see, we don't touch the guide with this implant stop here. We leave the space between the implant stop and the metallic sleeve. Now, adhesion site, same steps, 3.2 millimeter drill. Fleshy movement in this symphysial area. We have a type 1 bone here. It's very demanding to screw up this very hard bone, and as you see, how many times Giampiero spent to prepare this dense bone with the fleshy movement preventing overeating.
Posso vedere un particolare?
Apri grande Marco. Screw tapping, reverse section. Questa la tengo dalla testa ora, eh? Tanto ho capito, devo registrarla dopo, che se non è più... Look at the finger of Giampiero free from, away from the device. And it's the system that drives Giampiero and the screw tap through the metallic sleeve. Removing the bony debris inside. When we manage, the screw tap produce a lot of bony debris, so we have to remove this bony debris that may interfere and provoke some spinning movement to the implant when we tend to force the implant down in the osteotomy. Apri grande. Grande. The implant is free, are not guided at this moment. We engage the bone. We have 30 Newton now. Look at the hand. La mano. Vedi? Apri grande, apri, fermo. Bravo Marco. Third bleed implant is down. Not at the right final position.
Bisogna comprare le fasce perché ribaltano indietro.
Ok. Apri grande Marco, grande grande, fai l'ultimo sforzo. Look at the instrument of Giampiero here for controlling all the vibration, and you feel if you enter in deviation you provoke some strange vibration. Control the vibration. One is taking by the other hand the reduction of the drill. Sorry, because we have some problem because of the mouth opening of the patient, but also because we have obliged to use the extension of the drill to show you better the movement. So we have more longer drill to manage. Because if we don't use the extension, we don't see anything. 30 newtons, screw tapping the bone here. Let you drive from the system. Don't apply so much force during this key phase. Remove the screw tap now. You have to rinse a little bit to remove the bony debris inside. We want the freedom over preparation in length, control all the apical impairment that may not allow the implant to go down in the right position. Così. We ask the patient to open the mouth at the maximum in this moment. Reverse section. Engage the bone in Questo si batte molto a piccolo. Batte molto piccolo. No? Now, according to our protocol, we unscrew all the implants for releasing tension in the system. We are using now the manual screwdriver to go faster to manage the unscrewing the implant, because the motorized device is not able to unscrew the implant in this place. But as you see, now is the moment that all the implants are in place, not at the right depth, but we release tension. Now we set 35 newtons now, and we try to go down. Now the first implant is down, not so easy to see on the camera, but this is the other implant. Third implant now, down now, okay? There's not so much deviation here. We unscrew a little bit. And we jump to 35.
35?
And we are able to reach at 35 newton. And 55 also here. So we are taking a mirror to show you the situation in this moment. All the implant seems down. We have to check the fitting between implant mount and the we take the blade now. There is some little gap here. Lo faccio vedere. Tutto qua.
Apri Marco.
Allarga, vai che è meglio. Allarga. You have to, as you know, there is a perfect control of the fitting by checking if the hexagonal stop of the implant mount touch the guide in a flat-to-flat manner without any deviation. Every time we can unscrew the implant a little bit and screw it again. We can jump here with internal connection and we can force a little bit at 40 Newton, but not more.
Apri Marco.
We don't need 50 Newton.
Oh, fermo adesso, apri Marco.
Poi tutte e due o solo sopra?
Solo sopra. Lo fai?
This is the situation, the same image that we see on the software before the surgery. And all the implants are driven flapless without cutting any, without opening a mucoperiosteal flap. Okay. We take an instrument.
Spegni la musica, ma scusa, registrare.
No, ormai. We had to use an instrument here to control the unscrewing movement in this moment. Apri grande grande. We have to control if the fixation screw of the implant mount is free from the connection, and as you see, it's not possible to lose this screw into the mouth of the patient thanks to the quality of Nobel Biker kit. I'm checking now the questo forse non lo ok. Oh, it's free from the connection. All the implant mounts are free, and as you see, it's very easy to remove the implant mount. It doesn't mean that this implant is not so much tension in the system, because thanks to our protocol, we insert not so much deviation and not so much tension. Then we release the tension before sitting all the implants down. So we expect that everything's going in the right way. This is the moment.
Apri grande Marco con la bocca chiusa.
And as you see, it's very easy to see the implant inserted with the purple color. It doesn't mean narrow platform for the implant. And we are approaching to remove the remaining tooth of this patient. This is that's so-called the terminal dentition for this patient.
Modello, devo preparare i mocconi, poi faccio
This is the moment. We check the situation. You see no bleeding, no need for any suture corresponding to the placement of the implant. Difficile per la laterale.
come facciamo sempre.
Sì, sì. We have to show this, the effects of flapless surgery, no bleeding, and we expect not so much swelling and pain. Now we are approaching to remove the tooth. With the use of periotome we start to, because also the extraction of the remaining tooth, above all when we plan to place the implant into the socket, but even if in this situation when we plan the implant away from the socket, we have to proceed to extract the tooth very in a traumatic way, not to provoke any breakage of the bone of the buccal plate. Because we have the implant very near. First for the healing of the patient, and then not to introduce some variable. So also the extraction has to be minimally invasive. We manage the periotomy all around the tooth. We are lucky this we are checking the movement by luxating a little bit before extracting. We are checking the mobility, above all, of the canine, because we know we are the harder tooth to be extracted.
Tocco il mouse devo vedere dentro se era possibile, se avrei bisogno di vedere. Se tocco il mouse di là bianco è andato in pausa.
Mi sembrano abbastanza di vuoti che abbiamo dall'attacco. Then this mobile tooth is very easy to be extracted. After the use of the periotome and luxating, some slight circular and slight buccolingual, not so much buccolingual, we prefer some circular to avoid some breakage of the bone. I put the finger on the buccal plate to feel some problem here. Don't be in a hurry to extract the tooth. It's the final part of the surgery, but every part has importance, you know. And then the last one, premolar. So we have to retract very well the tongue. È venuta tutta? Sì.
Tira dentro.
Now, we have removed the tip of the tooth. We have to clean the socket, you know. Remember that we have not the implant side, but we have to remove all the granulation, soft tissue, and all the chronic infection around this. Sì? Yes, stacca la luce. Vedi? Now, we go on with the prosthetic phase. We are applying this abutment, this gold-colored abutment from Rain. It's named OT Bridge. This is the name of the. It's like multi-unit abutment, but at the advantage that we can engage. We are studying if there is a candidate for our next future steps to managing the application of the pre-made prosthesis. And as we show now in the moment, we want to show you the similarity of the master cast. Faglielo vedere anche loro.
Deve essere
Qui. Aia. Vicino alla bocca. Guardate la camera.
uguale a quello
Okay.
che è vicino.
This is guardate Edo, guarda il televisore. Devi entrare nel campo un po', tanto adesso un po' più su. Un po' più su. Ecco, devi imparare a muoverti. Ok, this is the master cast of the pre-made prosthesis, and this is the situation into the mouth of the patient. We plan to touch some soft tissue that may interfere with the sitting of the prosthesis. Giampiero checked the situation before the surgery and as you see, we manage this mucosal interferes by removing using a large diamond bar without water, because without water we can remove very easy the soft tissue, but it's like a burning of the gum, so we can not provoke so much bleeding to have a best visibility during this touch of the gum, of the mucosal interferences. And every time we have to detect which kind of interference we can have before the sitting of the pre-made prosthesis, because sure, when in the extraction site we have some mucosal or bone or both mucosal or bony interferences that will have to be removed. No, look. When the amount of the dove? Devo lavare? Okay. When the amount of the reduction have to be more. Okay. You can use the blade because we risk to use the bar very near to the abutment. And we try with the processes. Fammi vedere gli attacchi sotto se si vedono i Seeger. Vedono? And this is the pre-made process. And as you see, io la prendo del tutto. As you see, okay. Inside of this temporary abutment soldered to the bar. We have some acetalic resin here. It is part of the concept of this particular rain OT bridge abutment that maybe can easy or help us to apply better the processes onto the abutment screwed, already screwed. This is the moment that we try to fit the process by pushing with finger, and as you see now, we see the perfect engaging immediately of the processes that thanks to this acetalic part, and you see we can easy check the possibility. Oh, sorry, la mano davanti. You can easy check the processes immediately fit onto the abutment, and then we can screw. The advantage of this abutment that we have this possibility to have the immediate engagement of the abutment, and then we can go by screwing. Maybe we are checking because there is no particular tightening force to applying to this. Screws. The company said to us is enough to screw by finger, but we have to ask to Rain which is the final torque and tightening force to apply to this screw. C'è un torque di riferimento? 18?
Perfetto, l'unica cosa che mi cercare mi riferisce non che casca mi si apre. Ok.
And then we are sure that we are at this point we know that we are able to engage the bar, the framework inserted inside of the prosthesis, and then we are screwing.
Indietro, giù così.
Scusa Marco, abbiamo fatto e sono i denti, dai.
Non riesco a ingaggiare nulla.
Mi sa che si può lavorare con questi abbattimenti allora. Mi sa che si può lavorare con questi abbattimenti. And we are able to feel by the finger the possibility to feel the screwing of the prosthesis. So we try to use the motor device at 50 Newton, like the angulated multi-unit abutment from Noble Biker. Maybe in this kind of abutment is enough. Ma sapete quanto reggono? No? Facciamo fargli delle prove. 18? Now we have to check the occlusion. You remember we are obliged to remove the upper prosthesis. Now we are placing the upper prosthesis to check in the occlusion first, and then we will go to managing the X-ray control to control the fitting of the prosthesis. And then is the key point that we ask to the patient to close the mouth immediately. And as you see, the perfect situation, thanks to the protocol, thanks to all the things that we say yesterday about the articulator, about the using of the radiological index, duplication of the denture, and everything is going the right way because the great potential of the planning, parallel implants, good managing of the surgery, and when we check the occlusion like this, we have the great sensation that everything is going the right way, but Anyway, we had to take an X-ray control now.
Allora,
Apri bocca. We removed the lip retractor by managing some
Marco, abbiamo quasi finito.
a better viewing of the occlusion of the patient. So, flapless surgery, atraumatic extraction, good planning. And as you see, the wonderful result that we are able to reach at the very end of the surgery without any suture. And also we have some little sedation here and anesthesia.
This is the panoramic X-ray control, the post-op control. You see the fitting, the perfect fitting of the pre-made prosthesis. Is the good result according to our protocol to apply the pre-made prosthesis with guided surgery, and see you to the next lecture.